Good morning, everyone. I'm going to rattle through an awful lot of slides with a lot of data. The point is not to dazzle you with science or information, but actually just to highlight a few issues. Most of the data is available on that website, the GSNA website, but I'm more than happy to allow these slides to be available if anyone wants them, as I appreciate. I'm going to go through them fairly rapidly. Bit about the Director of Public Health post. We trace our history going back to over 150 years with David Duncan. We started off really as part of the sanitary committees when housing was going up in Victorian times and people were having to decide who to move into new houses and what to do about all the unsanitary conditions, and they needed medical officers to help prioritise people. And those medical officers of environmental health eventually ended up as DPHs and were independent-minded, as you might imagine, because they would tick off councils and councillors about slacking on certain issues that were relating to health. And hopefully I won't be ticking anyone off, but I will be pointing out some of the challenges that we face. Now, in terms of Bristol, I assume all of us are proud to be Bristolians, proud to live in Bristol or be linked in Bristol. That's partly why we're here. And it is a great place. We know it's a great place. It's attracting lots of people. The population continues to grow, and it's a young population. And that also means that we've got more energy and creativity than a lot of other places. As Marcus has said, I've worked in the north. The average age up there is about 41, and the issues about an older population is much more acute there. If you compare our population, this is just saying the same thing in a slightly different way. You can see that the birth rate and the number of births is going up. We've got a significant population compared to the England and Wales average. That's that population pyramid on the right-hand side. I don't think I can point on it, but that's a traditional population pyramid. And the dark rectangles are Bristol, and the green is England. So you can see that we've got more working age and kids and less of the older population. Okay, so it all looks pretty average. If you compare ourselves with the rest of England, we're pretty average in most things. But when you actually apply the lens of knowledge and data, what happens is that you find that it's not all average. What we've got is significant amounts of people doing really well and people doing really badly. So, so we're comparing areas such as Lawrence Hill, Southmead, Knoll West, with some of the other areas in the inner northwest. So in terms of geography, I'm going to produce some data that breaks the communities into those 5 areas: inner north and west, inner city, Bristol East. These aren't necessary. These are coterminous with wards, just for analytical purposes' sake. But what we've done is looked at data and found that people in those areas have some similarities when it comes to health outcomes. The first thing that you do when you look at the health status of people, paradoxically, is look at the people that have died. Why is that? Well, death is pretty unequivocal. We don't have a doubt whether someone's in pain and how much pain. There's usually no doubt about it, that you've died. And we can look at premature mortality. And when you look at premature mortality, that's all the wards. Bristol's average, as I've said, is average for England. It's pretty average compared to that lot. And you can see the range in terms of premature mortality between Lawrence Hill and Stoke Bishop. Okay, it's pretty stark, I think. So when we start to look at those areas, we can break down that premature mortality in something that we calculate called life expectancy. And as you can see, all those areas are different. You can see that Bristol comes out pretty close to the England average. We've got slightly worse life expectancy than England when it comes to male life expectancy. But you can see that range which says that actually if you happen to live in inner north and west, you're doing really well. And if you happen to live in some of the other areas, in the case of women, it's outer north and west, which is worst off, and it's inner city when it comes to men. So we've got variability. And I suppose what I want to do is just explain and try to explore why there is variability. And then I think the challenge to us, and I think the challenge to the city, and remember we all have established that we're proud of being in Bristol. We've got 25 families bereaved every fortnight from diseases that are preventable. That's the human side and the human cost of what I'm talking about. We're losing people, we're losing valuable people whose death could have been prevented. So starting with life expectancy, I've got to say, first of all, that's a synthetic estimate. You know, nobody's got a time machine that says you're born today, you're going to die later on. What tends to happen is we use a calculation that allows us to work that out. And, you know, life expectancy has been rising. It's been rising nationally. But there is a gap between our most affluent areas and our poorest areas. So you'll only live to 75 if you're a boy in Southmead or Hartcliffe, but you'll expect to live to 84 if you are born and live in Henleas, and you know, ditto Clifton, Henleas and Southmead for girls. That, I don't know how that feels to you, but it just feels inherently a little bit unfair from my point of view. It's not just about life expectancy, it's good life expectancy. And so whilst women do live longer, I've got to say that if you look at people living with some kind of illness in their lives, we've got about 75% of our lives healthy, and 25% if you're women, 25% of your life with a condition of some description that makes you feel unhealthy, say that you're not in good health. For men, it's not as long, but men don't live as long. So whilst it's 80% of their lives, they keel over and die sooner. That's great to look forward to, isn't it? As it for my finish. When you look at early death, and you know, again, statistically, we talk about early death as being before the age of 75. You can again see a significant amount of variability. And the rates, as I've said before, vary considerably from Lawrence Hill to Stoke Bishop. So that just presents geographically that bar chart that I presented. If you look at how well or badly we do in terms of disease, again, this table represents those 5 areas with Bristol. Sorry, I just need to be able to speak. I think that's the problem here. But you can see inner north and west feels like a different place than some of the other places. And actually, when you start to look at all-cause mortality, but you break it down by cancer, coronary heart disease is what CHD stands for, or coronary vascular disease, the difference being that coronary heart disease is coronary vascular disease includes stroke. You can see there's variability there, and you can see what the size of the challenge is. It doesn't need me to tell you that. And it's interesting, isn't it, when nobody walks around, well, not many people walk around without shoes and tattered clothes in the same way, but our poverty is expressed in slightly different ways now, but we still have it. I mean, if you just talk about it in stark terms, your chances of getting out of 100 children that are born, I think the figures are stark enough. If you are living with a smoker, for example, if you're in a household with smoking, your 44 children in Lawrence Hill will live with someone who's a smoker compared to 15 in Cottam, for example. Job seekers allowance, 1 person in Cottam compared to 10. The challenges and the inequality across this city are stark. Okay, that's what that table shows. So how are the other things? I've started with death. What are the other things we can measure? We can measure, we've got something called, it's a weighing and measuring system where we look at kids the age at reception and year 6. And again, you can see how that plays out. We've got some stark differences when it comes to children being overweight. Now, there is a debate and discussion whether that in itself means that you grow up to become an obese and overweight adult. And we know we've got an increasing issue with being overweight. I think, if I'm honest, the evidence base isn't quite there yet, but there is a sense that if you're a fat child, you may end up being a fat adult. And the least we can do is try to measure where the differences are and alert parents, because beauty is in the eye of the beholder. Sometimes a bit of a shock when you think my child's healthy, when someone tells you, well, actually they might be a bit overweight or obese. And you see it, kids struggling to do physical activities. You're building a cultural expectation that you won't be able to do things like that. Child poverty. Again, I show the chart in front of you, which shows that there's a significant gap right across this city. And I could prattle on, but I think the charts and the maps speak for themselves here. One of the ways you measure the state of children that are born is to measure the weight at which they're born. I remember always being fascinated as a child why everybody wanted to know the weight of the baby that was born. And it's basically just a reflection of how healthy and what are the chances of that baby surviving. And again, you can see there's clearly a gap. And I don't know if you've noticed that pattern, that the inner northwestern always seems to come out a little bit better than anywhere else. Just rattle through that. So we also do a quality of life survey, and the quality of life survey asks things that you would normally expect us to ask. Do you smoke? Are you overweight? And obviously most of us tend to underestimate our weight and overestimate our height. But even there, you've got a stark gradient. The things that we know are good for you, like exercise, eating vegetables, not smoking, certain people living in the least deprived areas do more of than those in the most deprived areas. Am I telling you anything you don't know? Probably not, actually. But the point is, as a city, what is it that we need to do to help those individuals and those communities that don't adopt those good behaviours? This is, again, the same data. I'm sorry, I'm hammering on and on about it, but that is the inequality in our city. Our city comes across as an averagely good kind of place. We're certainly a lot better than the core cities that we often measure ourselves with, but they're often northern cities in old industrial heartlands, and they've got entrenched problems that relate to no longer having those industries. As I said, we've got a creative drive. But at the end of the day, we have within our own city a huge amount of variability. So I suppose what I'm saying is, in terms of the challenge to the city of Bristol, we've got actually a significant degree of entrepreneurial capital. We've got a lot of intellectual capital in our universities. The people that live in Inner Northwest do really, really well. How can we get their behaviours? How can we share those behaviours? How can we support those communities who aren't doing so well to adopt the same behaviours that are found in our city? I think the challenge for us is, how do we bridge those two communities so that we can assist? Now, certainly someone who would see themselves as having a bit of intellectual capacity, I think the challenge is, how do I reach out to those areas that I've talked about, Knoll West and other areas? How do I help support those communities? Now, I've got an advantage, as there's a department, there's a series of activity, but I think the amount of money that there is that I've got is trivial, actually, compared to the size of the challenge that we face. And what we've got to do is engineer a way that all of us living in some of these affluent areas can help those people that are living in poor areas. It's got to be at scale. So that's me. Thank you very much.